Now we're going to talk about menopause management. What's the difference between menopause and the perimenopause? Are they really that different? Well, let's see. Menopause is the permanent cessation of menses due to decreases in ovarian estrogen production. This is evidenced by 12 consecutive months of no menstrual bleeding. So it's usually a retroactive diagnosis. Versus the perimenopause, or the climacteric, which is a transitional period which can occur from 2 to 8 years from reproductive to non-reproductive stage. This is marked by menstrual irregularity. Let's review how the perimenopause works. In another lecture, we reviewed oogenesis. Oogenesis begins at 4 weeks, and the peak oogenesis occurs mid-gestation, and then we lose follicles through atresia after that time, through birth, puberty, and all the way to the menopause. At birth, we have 1 to 2 million oocytes in our ovarian reserve. By puberty, we have about 500,000. And by the age 30 to 35, when you're advanced maternal age, you have 100,000. By the time we get to menopause, we have less than 1,000. Let's talk about the hormones that are actually increased. So we know that follicular stimulating hormone, or FSH, increases during the menopausal period. We also see a corresponding decrease in estradiol production. So the mechanisms that increase FSH are follicular atresia, leading to decreased ovulation, decreased estradiol, and that increases FSH. The remaining aging follicles exhibit diminished capacity to secrete inhibin B. This also leads to increased FSH. Premenopausal FSH levels should be less than 10 ideally. Sometimes in the perimenopause, we can already start to see an elevation in the FSH. And by postmenopause, we see that the FSH is greater than 30. In the perimenopause, be careful. Women can still become pregnant. In fact, they're more likely to ovulate twice and have twins. Let's now talk about estrogens. Estrogen levels do not gradually wane, but remain stable, and sometimes they're slightly elevated due to the high FSH. Let's talk about the different types of estrogens. We have E2, or estradiol, and estrone. Estradiol seems to be the only one to decrease less than a year before menopause. So in premenopausal women, usually we make about 30 to 200 picograms per milliliter. In the postmenopause, we have much less, at 25 to 30 picograms per milliliter. We're going to talk about how that feels for a woman after being exposed to estrogen her entire reproductive life and then losing estrogen. Then we're going to talk about estrone. This is an extragonadal estrogen, as it's usually made peripherally, but can also be made in the ovary. This is the primary estrogen in the menopausal woman, and the premenopausal levels are between 35 to 500 picograms per milliliter. In the postmenopausal range, it's 10 to 15 picograms per milliliter. So how does this work? The hypothalamus usually gives input from through FSH to the ovary. Typically, FSH works upon the ovary to make steroidogenesis actually occur with the addition of luteinizing hormone. Aromatase converts androgens to estrogens, and the estrogens feed back to the pituitary and the hypothalamus. This happens when we are in our normal reproductive phase. Aromatase in the postmenopausal woman actually causes peripheral estrogen production, primarily estrone, which also feeds back to the hypothalamus and pituitary. Let's now discuss the endocrine profile in the perimenopause. I don't want you to think that you need to check hormone profiles in women to determine if they are in their perimenopause or menopause. Remember that menopause is a clinical, retroactive, or retrospective diagnosis that you can only make after the patient has 12 consecutive months with no menstrual bleeding. However, I do want to call your attention to the fact that there are some hormones that start to decrease or increase in the perimenopause. One such hormone is anti-Müllerian hormone, and it starts to decrease to undetectable levels 5 years before the final menstrual period. And the decrease in AMH actually corresponds to an increased chance of twinning. Therefore, women in their perimenopause need adequate contraception. Let's now review inhibin B. Inhibin B starts to decrease in women who are 35 years of age and older. Remember that 35 years of age in obstetrics is advanced maternal age. Finally, luteinizing hormone. Because of the decrease in inhibitory factors, LH is increased during the menopause. Lastly, testosterone decreases by about 25% due to adrenal cortex hypoplasia and the loss of cyclical LH surges.